Great. So just to tell you a little bit about myself, I moved to San Francisco in the Bay Area about 4 years ago, and I started working at Rock Health, which is a digital health accelerator. It basically means that it's a school for startups, and Rock Health is really focused on digital health or eHealth startups specifically, but ones that serve all populations, not just vulnerable populations. So I got my start there really learning about how health and technology, and specifically health and technology startups, operate in the United States. From there I moved to Zero Divide, and my work was focused more on vulnerable populations, so low literacy, low education, low income, generally just populations that face a lot of obstacles and barriers to accessing health care. And my work was focused on product development and engaging with vulnerable populations there through technology. And so now I have my own consultancy, Riveted Partners, that focuses on that, as well as another venture, P2 Health, which I will talk about later in the presentation. So just a little bit there. I won't spend a lot of time on this because I think Patricia did a wonderful job talking about this, but this is just how the United States Department of Health and Human Services talks about the social determinants of health in these 5 areas. So there's health and healthcare, which is a pretty actually small part of what determines what makes us healthy in terms of access to care. The bigger pieces are this social and community context. So really thinking about, in the case of race and ethnicity, like discrimination that people encounter and have to cope with, this degree of social cohesion, so living in neighborhoods where you don't really feel like that you trust people around you or that you are connected to people around you. There's the economic part, which of course low-income populations face a number of obstacles in being healthy, whether it's having access to healthy food, practicing being more physically active, having the food security, stable employment. Those are all obstacles to being healthy. Education, of course, being able to know where to find information, know how to source information and process it, and then the neighborhood and built environment. So the same, talking about access to healthy foods, quality of housing, crime and violence, and just your sort of environmental context. So those are all the sort of 5 major factors that affect how healthy we are. So I wanted to talk a little bit more about numbers. So these are more specific to the United States, of course, but wanted to talk about how much do each of these social determinants really contribute to overall health. And if you look at what the U.S. healthcare system is spending versus what's actually driving those healthcare outcomes, over here, these are the numbers that this is what's making us healthy. So about half of what makes people healthy are healthy behaviors. It's eating well, being physically active, sleeping, managing stress, maintaining positive relationships, so all behavioral factors. Another 20% for an environmental factor, so living in a neighborhood that's pretty nice, safe, those kind of things. And then there's another piece for genetics, like do you have a genetic predisposition to other chronic diseases? And then a very small part on access to care. It's basically only about 10% of access to care is really driving healthcare outcomes. But what we spend in the United States, by and large, is on healthcare services themselves. And so there's this disparity in between just even on a financial perspective and thinking about what our focus should be on, especially when we talk about these healthy behaviors, because this is where a lot of those social determinants affect the ability to have healthy behaviors and maintain those. So that, this dollar figure here is 4.5 billion. So I'm in Silicon Valley. There is a lot of activity around what in the U.S. we call digital health, but what is eHealth. And so this 4.5 billion represents 1 year of investing in startups. This is just 2015, and it goes up every year. It's the largest year that has been recorded yet. But when you kind of dig deeper into where this money is going toward and what it's being invested in, The top 6 categories accounted for half of this level of funding, so $2.25 billion. And those top 3 categories are things like payer administration, so just kind of being able to process the revenue and claims and everything. Telemedicine, which is still growing in the United States, but still facing a lot of obstacles because of the way that it's regulated, because it's regulated on a state-by-state basis. And then care coordination. So does Dr. A, do they have the ability to talk to Dr. B? Do they have the ability to share records and actually be able to see where the patient is going as they manage their complex condition? So those are the top 3 categories. But those are still care, like that's still medical care services. The other 3 categories are things that would probably be more on the preventative side of the equation. They're things like consumer engagement, wearables, which are a huge category in the United States in terms of what digital health is focusing on, and kind of these personal tools and tracking. But as Patricia said before, like there's a lot of tools. I think the last count I heard, there's something like 50 wearables available in the United States. But when you look at the price points, they're not accessible to people who are low income. Oftentimes they're measuring things that are not necessarily going to drive long-term behavior change. So if it just tells you, well, you should just eat better, but you live in what's called a food desert, so you don't have access, it's very hard for you to access healthy food, then that kind of advice doesn't really translate into the health outcomes that we want to see. So there's definitely a lot of money in the United States being focused on technology and healthcare, but it's not really going to the populations that need it the most. And then I also wanted to share another number too. So in the United States, preventable health problems, things that would be really great to use with technology, still account for $260 billion a year in spending. So this is a lot of money that's just going to waste. People are living sicker, they're living shorter lives, and it's costing a lot of money. So kind of, what are some of the barriers that we're talking about, like how tech can address this? So in my work at Zero Divide, we did a lot of research on what are barriers to eHealth, and they fall into these broad categories here. So there's education and awareness. This includes things like privacy concerns, for example, and distrust. So if a low-income consumer is using an app, can they trust that their data is going to remain safe? Health literacy is a very huge problem, which I'll talk a little bit more later. Physician awareness, and then also incentives to using. A lot of the research that we actually did, it wasn't so much, physicians are very confused about what technology is effective and what they should use with their consumers. And then there was also a lot of pushback on wanting to use technology, whether that was sharing their notes from particular visits, whether it was actually answering questions if the patient came in with a phone and they were tracking symptoms or they were tracking their medication adherence. There was a lot of resistance to wanting to engage with that information. And then lastly, of course, the patient or consumer awareness of eHealth. So those are all education and awareness barriers. Then sort of we move farther up. Like this is like the reason why I depicted it this way is that these are kind of at the end of the more like insurmountable, like huge, more infrastructure kind of barriers, and these are more kind of interpersonal in the education awareness. So right in the middle, the design and usability. So limitations caused by disability. Sometimes when you open these apps, the font is very small. If you're an elderly person trying to read this, it's very difficult if you have poor eyesight. The linguistics, cultural competency of tools, a lot of the personal health tracking tools that have food recommendations are really for a particular population and don't cover others. And so if you are someone who is from Asia and you get a recommendation that you should stop eating rice, like what is the likelihood that you're actually going to do that? Rice is a core part of your diet. It's part of something you share with the family. It's very unlikely that's going to happen. So there's a lot to be done on the sort of more competency side of things, and then it doesn't even get to the language barriers that are also profound too. And then on this last piece, the digital divide, interoperability. I don't know how many of you are familiar with this term, but it's the idea that as technology is being developed and as it grows, like the ability for each of these products, tools, and infrastructure to talk to each other, engage with each other, is very important. In the United States, like, this is something that has kind of turned into a battleground in this particular area. A lot of the huge companies, like the big health IT, kind of electronic health record companies, have been very resistant to making their products more interoperable. In other words, to make their products more open so that people can engage with them more and share data. And that's because there's a market incentive for them not to. They make more money if they keep their systems closed, if they keep them difficult to use. And so there's a very hard policy dance of trying to get them to open up more of their data, and it's starting a little bit, but it's been very, very slow going. And then for the United States, we still have, so as Robert mentioned before with Zero Divide, the original mission of Zero Divide when they started was focused on this concept of the digital divide. There still are limitations on access to broadband internet in the United States. I believe the last figure I saw was anywhere from 20 to 25% of Americans don't have access to broadband internet in their homes. They'll use things like the public libraries, they will somehow borrow internet, or in most cases they will rely on a mobile phone for access to the internet. So all of these things become more difficult if you have something like a website where a patient needs to log in to see patient data or log in to see what their records are, and they don't have a computer at home. Then you're really not going to see the expected outcomes or behavior that you're hoping so that people can be healthier. So those are kind of like the three broad barriers. So kind of, what do we do about that? That's the problem that we've got. So as we mentioned before, this idea of like co-design, and then I also want to add in this idea of smart prevention as well. So in terms of co-design, of course, so for this idea of better care and chronic disease management, you want to aim to design with patients and consumers rather than to design for them. They need to be in the room literally from start to finish. They need to be involved in the entire process. And I like to kind of liken this to, everyone in here obviously is wearing clothes. You chose a particular garment for whether it was aesthetically pleasing or there was a purpose that it served. But the idea is that those clothes were designed for you in a certain sense. Like, they took fit into account. They took color into account. There were all these considerations in this process of you, or at least like a version of you, being involved in that process. The same thing needs to happen in healthcare, and we're not seeing that right now. Like, right now we see kind of this one size fits all, and then sort of copying that out over a very large population. And then this idea of smart prevention. How can we, in the United States with healthcare reform, now a lot of there's a package of preventive services that are provided at no cost, but the sort of, it's beneficial because people are getting screenings, they're getting checked out by their doctor fairly regularly, but there's a potential, and this might be a reality, that it's actually going to end up costing more money because there will be a lot more people getting preventive services that they may not need. So you're going to spend money on prevention, you don't see the return on that for a very long period of time, but by then you've spent a lot of money already here that could have been better spent, like had you known a better idea of who needs to get preventive screenings or procedures or things at the right scale. So how can we use technology to better understand how we spend our money on prevention properly, both primary and, so primary prevention, so preventing a disease from occurring in the first place, and secondary prevention, this idea of keeping it from getting worse. So really getting into more specifics. So one of the first lessons that I want to share with like my work is like this idea of solving the right problem. You would be amazed in the United States, like I told you before, like the $4.5 billion that's being invested right now in health and technology, that actually represents a lot of waste because it's people chasing after solutions that are solving the wrong problem. They're chasing after things, they're not solving problems that people either need to be solved or that they want to be solved. And so, how can you think about doing this? You really want to identify opportunities that are measurable, first of all, beneficial, and then impactful. So kind of thinking a little bit more about doing this. So there's this idea that like if something is measurable, beneficial, and impactful, it may not be the most important problem, but it could be an easy start for you. It could be like an easy problem to solve, which is still beneficial, because if it's easy to solve, why wouldn't you want to do it? It could be very fast to solve, or it could be very inexpensive. And then it's this idea that in general, innovation is very hard, regardless of what industry you're in. Healthcare is particularly more difficult because we have patients' lives in our hands. But if you could find something that is easy, fast, and or cheap, that could lead to opportunities for future funding, future collaboration. It's the idea that you kind of start small and you work your way up to solving the big, major, complex problems. So really, this goes back to the co-design that I talked about. You want to understand your customers and the context that they're in, and do your research to inform your hypothesis. So that, of course, is looking at all the research that's been done before, but a lot of maybe going to go visit your patients where they live, like go around their neighborhood and kind of see what they encounter, understand like what kind of jobs they have. If they're working shift jobs and it's 12 hours and they really don't have the time to sit down and have healthy food, like how can an app like really help them either to remind them to eat healthier or move more. And so I want to talk about one company in the United States that's really focused on this, that's called Care Message. And so Care Message is really, their aim is to solve chronic disease management, but it's through improving healthcare literacy. So they're a nonprofit tech company. They have a text messaging platform that delivers, has, I think, last count I saw, somewhere between 25 to 30 programs that are focused on increasing the health literacy of at-risk populations. So within the United States, they really focus on the safety net population, so the kind of low income, low educated, low literacy populations. And it could be delivering text message on anything from, if it's diabetes, reminding people to check their blood glucose regularly, to check their feet, their eyes, like the sort of anticipating potential complications, and keeping people engaged in their care in a way that is not burdensome, that is not costly, and that is also like accessible. Even if these particular patients don't have a smartphone, everyone can get text messages on what are called feature phones, the same flip phones that are very inexpensive. And in the United States, we have, I'm going to forget what the official name of this program is called. Most low-income communities call them the Obama phone program because it gives them a free phone. And it started with the Obama administration, but there's an official technical name for this. But it's possible to get a free phone. So if you know that everyone's got a phone in their pocket, in the United States, the cost of low literacy for our economy is anywhere from $106 billion to $238 billion a year. So this is a huge problem that Care Message is solving. It's a huge problem that not many people are addressing. I think the last I heard is that roughly 70% of American patients forget what their doctor told them within 10 minutes of leaving an appointment. Yeah. If you only have an appointment maybe once or twice a year and you don't remember anything, what are the odds that you're going to remain adherent to your treatment? What are the odds that you're actually going to improve? So really, like with Care Message focusing on this health literacy problem, they are, it's a small, relatively low-cost intervention, but it's going to have very huge impact. And the benefit is, that I talked about this, there's the impact, so that's the impactful part of it. Beneficial, obviously, that people are staying engaged, staying healthy. And then there's the measurable piece, too. It's a text messaging platform. You can see how fast you can see the open rates. You can see how many people open them. You can see how many times they're replying back. You can see, like, what kind of replies they're getting. There's so much data that's coming out of the way that they're now engaging through their product, that it's very easy to see and understand where they need to learn from and do better in terms of reaching their consumers. And so, yes. And so for example, the health literacy statistics in the United States, so I think, let me read this correctly, only 12% of U.S. adults have proficient health literacy in the United States, so we're actually worse than here. And then roughly, so more than a third of those, about 77 million people, would have difficulty with common health tasks, such as following directions on a prescription drug label, or things like adhering to a childhood immunization schedule. So these are very basic health behaviors that people need to do, and there's about 77 million people in the United States that are not capable of doing that. So this idea of solving the right problem, I don't know, how many of you have developed an eHealth intervention before or have one currently? Okay, a few people in the room. Yeah, so I mean, I would say for the rest of you that are either thinking about it or trying to understand, like really working to understand, you know, kind of good starting points for questions to ask yourself, like what are the biggest patient complaints that you get about like what they don't have or what they wish they had? And then also kind of like what are your outcomes of interest, like whether it's for cost, if you see something that's actually costing you a lot of money, how can you start going about it, understanding how a potential digital, like an eHealth intervention can address that. So that's kind of on the solve the right problem piece. And then this idea, you want to aim to include rather than exclude people not like you. So you want to go out of your way to bring more people in the room and not just like everybody. So this is both like something that you should think about doing externally as well as internally. So externally, I always like talking about this idea, especially with technology. There's this idea that people want to go rush out and develop an app. They want to go rush out and build a website. And before you go do that, the first thing that you should do is start asking questions, because probably 9 times out of 10, people have developed some sort of workaround to the problem that you're trying to solve. If it's a problem and it's big enough and it's important enough, then people are finding ways. So for example, at Zero Divide, a lot for our research, we were finding that there was a lot of issues with finding health information for people who didn't speak English as a first language. And so in this focus group research that we were doing, we found that consumers were basically using social media to spread information. So someone who was at least pretty health literate would post things on their page, and then folks would just comment underneath with questions or follow-ups, and then they would share basically through Facebook to be able to find healthcare information rather than using more to the popular health media sources that we have in the US, things like WebMD or Everyday Health. So like this idea of like these like workarounds, you want to find those, because ideally like your solution, the solution you build has to be better than that workaround, because if it's not, it's just waste. And we want to avoid waste. And then also we want to improve patient outcomes. So really trying to find those workarounds. And then, you know, maybe it's possible that there isn't a workaround for your particular solution. You also want to do your research and look around and see who else is trying to solve something like it or analogous to it or adjacent to it. You know, we'll definitely talk about an example more of this later, but you know, like it's as you start thinking about like design, you really want to, and like how you kind of hypothesize how you'll be able to solve this. Like it's really important to don't just focus on the technology. The technology is one part of this. The technology needs to fit into this idea, it needs to fit into a workflow. So it needs to be a process that follows that. If it's something like a patient monitoring kind of solution, then who's monitoring it? What happens if something really terrible happens? Like who's in charge of stepping in if an emergency arises? You know, are there other people that you need to involve besides not just the patient? Are there other caregivers or other folks that are kind of in their circle that will help coordinate? So this idea of not just like looking at the product in isolation, but considering the context that it's going to need to be situated in is something that you want to do earlier rather than later, because you don't want to get to a scenario where it's like this product is so fantastic but no one wants to use it because somehow it's burdensome. And I've seen this a lot actually with physicians. There's a lot of technology being developed for physicians to supposedly make their job easier, and it actually makes it worse. It adds time to their day. That's less time they get to spend with patients. It's not time they get to charge for. And so it's costly, and it's costing them time, which is also money, and so they don't want to use it, or they refuse to use it, or they use it very poorly, and then everyone loses because something has now been bought and is continued to be paid for, the patients are suffering, the physicians aren't using it, and it's just a terrible situation, and then you end up in this scenario where everyone feels burned and then doesn't want to try anything else new. So you want to try to avoid the scenario where you've burned your bridges, like try to ease yourself into something that's successful. And really thinking about this, like including like versus excluding as well. So I think I talked about including the patient and caregivers. This is also something, it's not just even just for the design, it's also a means of providing greater patient security, and it also is a way of earning their trust. Generally when patients feel heard, they tend to regard things pretty positively, as would all of us. If we feel heard, we regard things pretty positively. So this should be no exception. Like, you want to try to think about, like, what you would feel like if something like this happened to you, if something really terrible happened. And so that's kind of externally, like focused on things that are outside of whatever setting that you're operating in. Internally, you also want to think about too, like who's on your team that potentially comes from this background, you could be working with side by side every day. So with the United States, especially looking at tech overall, there's a big push towards diversity and inclusion. A lot of the messaging around that is focused on, in order to be innovative, you have to have people from a lot of different backgrounds, a lot of different ideas in the room. And this is definitely no exception, especially with healthcare, people who come from particular backgrounds, whether they grew up as refugees, whether they grew up having to always translate for their mother when she went to the doctor. Folks from those backgrounds will be able to kind of point out problem areas before they get too big for you and really add to a product that is more robust and more helpful for consumers who are not kind of currently engaging with the current healthcare system. Kind of building in this like lived experience. So kind of an example of like where a U.S. company has really taken this to heart is called Healthified. They're a software company that aims to help health plans and health systems coordinate and manage the social needs of their population. So all of those social determinants of health that I talked about, only one of those was healthcare. Healthify is really concerned with the other 4 areas. And basically how they work in terms of, you think about the inclusion piece, is that they connect patients to community services to help resolve other issues that are impacting their health. So whether this is housing, whether it's transportation, whether it's like access to food stamps and food security, and then through their platform, they're able to track and make sure that people are both getting referrals and making sure that those are followed through and carried out. So this idea of engaging with people who are completely outside of the healthcare system, which is still pretty new in the United States, but very necessary. But it's starting to grow, and including other maybe like less sort of workers who aren't considered to be more healthcare workers. So a lot of Healthify, of course, works with a lot of social workers, case managers, and a lot of more kind of more community-based agencies to really help these high-risk populations through this. And so as I said before, 60% of our health is affected by these social needs. And so for the United States market right now, like those needs, like things like food insecurity, housing, substance abuse that go unaddressed are linked to an additional $85 billion in Medicaid spending. So Medicaid is our low-income health insurance program in the United States. So definitely another very huge market that Healthify is addressing. There are very few people who are addressing this, and there's this idea too of like they have a big market opportunity, and then it's also helping patients be healthier. So test and iterate. This is always hard in healthcare. How do you test things without risking patient safety? How do you do it without spending a lot of money? How do you gather data that you can learn from and then be able to move forward? And so, I always like to talk about this idea of sort of testing ugly. What's the sort of easiest low-brow version of what you're doing that can be tested? So in the case of the SMS messaging that I said earlier, rather than necessarily going out and signing a contract with a company like Care Message for the next year and spending however many thousands of dollars up front, can you do something like some waiting room surveys and ask people to say, what helps you remember to show up to your appointment today? Like if we call you, if you get a text message, like how can you sort of do a really easy, quick version of that first before you commit to something ahead of time? You want to avoid the temptation to kind of run out and spend a lot of money building a website or developing an app when it's possible that people don't want to engage with you that way. In the United States, we're learning that a lot with these patient portals because there's been been a lot of obstacles to people using portals, like from having to remember passwords to the fact that a lot of portals are not mobile friendly. And so if you're a low-income consumer and you rely on your mobile phone for internet access, what are the odds that you're going to remember later to go find a computer somewhere else to log into your patient portal? And so this idea that people kind of miss this like ugly prototype first, and so now we're having to fix things. And so on the testing and iteration, so once you kind of have your ugly prototype, like how do you how do you sort of make changes quickly? Like, how do you know what changes that you need to make? So one question back to this idea that said that the tech is not the only thing, it's a means, not an end. You want to look at, are you using resources effectively? Does it require a lot of manpower to be able to follow up on these things? Are you constantly having to call support services? Are you going to have to do a lot of new hires and you kind of don't have any other way to use them? And so you kind of want to think about the sort of whole cost, and then it's like the whole sort of time using it. What are the right people using this intervention? If you build an intervention for low-income populations and you only maybe see that people who are 25 and younger are using it, but you want to get elderly populations in there, like what are you missing? Like what can you kind of iterate on to include those folks in their intervention? And then you also want to think about what the idea of workarounds, what would they use if it didn't exist? And then what is their world like now, and what would it be like in the future if this thing continued to grow and continued to scale? So another American company that's really done this well, this idea of testing and iteration, is called Health. They translated, there was a very large National Institutes of Health funded study called the DPP, I believe it's the Diabetes Prevention Program, that tested and validated this program, which was being delivered through community organizations like the YMCA or other kind of community-based agencies. But it was this idea that through this set of interventions, teaching people to eat healthier, small amount of weight loss, a lot of behavior change and social support as well, a lot through coaching, that you could slow the progression from prediabetes to diabetes. So this is a huge trial, validated across a lot of populations. They did a great job with clinical trial recruitment, but the issue was this intervention was being delivered in person. So there was the idea that people had to come in, they had to talk with folks, and so Omada was like, well, we have this program that works in person very well, how can we do this digitally? How can we try this out and test and iterate how to translate this in a digital forum? So they have this program called Prevent, which runs for 16 weeks and does the same thing, helps at-risk people, so folks who have prediabetes, slows their onset to type 2 diabetes. And so, they built that program and then kept testing and iterating on it for the last 2 years, and have proven results. They have proven that by providing this digitally, they now call it digital therapeutics because in the Valley they like to name everything. But for this digital application and using coaches online, that people actually both didn't acquire diabetes, lost weight, and in general were healthier. And so because diabetes, especially in the United States, is so associated with things like the social determinants of health, like issues with food security and physical activity and those sort of obstacles, they have now added features that are more designed for underserved populations because they realized they were missing patients that needed their help the most. Because in terms of their business model, they were selling themselves to commercial entities. It's pretty much the only way right now to make money in healthcare if you're a tech startup, unfortunately. So after they kind of had a couple years of runway and proved that they had this proven, they're like, okay, well now we really want to focus on folks who need this the most. And so they added features like they were trying to be more sensitive to food access when they suggested recipes. They now have bilingual coaches, so now they don't just offer services in English, they also offer them in Spanish. The rate of diabetes in Latino populations in the United States has skyrocketed, and I think is predicted to either double or triple in the next 7 years, I believe. And so definitely something that needed to happen, and they were just slow to do it, but have now incorporated that. They've also altered their curriculum, so it's accessible for people who have a low level of health literacy, as well as people who don't speak English as a first language. And then they have a clinical trial to assess these new features. So in addition to the fact that they built this, they now have a clinical trial, so they're going to, again, have validated results that this intervention is going to work in their population. So I think this idea of figuring out ways to test and iterate, there's a lot of discussion and movement around how to not strictly rely on randomized controlled trials because they are time-consuming, they are costly, and they don't really lend themselves very well to digital health interventions because of the fact that by the time that sort of the programming takes place, like you've kind of missed the window to actually be able to detect changes. And so a lot of like mixed methods and new experiment designs emerging to really demonstrate this. And there's a startup actually in the United States called eHealth that is trying to do this too, trying to validate and vet a lot of healthcare apps to see how well they work in terms of healthcare outcomes. So this last piece too, I have this thing. So I started working in health and technology coming from a global health background, and in global health it's a well-known concept, unfortunately, that there's this idea of pilotitis, that people design these pilots, they get a grant, and the pilot rolls out, and maybe it's in place for 1 year, 2 year, 3 if you're lucky, and then it dies because there's no financial runway. The data ends up sitting in someone's hard drive in some lab or in some university, and then no one gets to benefit from it. Not only that, you've burned bridges with the community because you've shown up and promised them these wonderful things. Maybe they really loved they loved the intervention that you were doing. Maybe they got a lot of benefit out of it, but then you left. And it's a question of kind of now what impact are we really having when we just rely on this sort of short-term like cycle of how we develop products. So you really want to focus on how do you build this for scale? How do you start at the beginning, assuming that, hey, we know that 50 million people have this problem, and yes, we're only doing this with 100, but how do we think about at this time point now at 100 for how we serve 50 million people? Because then you can think about ways that when you get to your intervention that you can be more sustainable. You can think about how you're going to share your results, secure the resources, secure the partners, other collaborations. And so, you definitely see this too in pilotitis. So the P2 Health that I referred to before, like that's really what I'm focused on, this issue of this failure to scale problem that's in the US. And so we're really trying to focus on fixing this in 3 key ways. I've started hosting a lot of events just to build more awareness around healthcare disparities, especially how tech can address those. To kind of increase the literacy within both the healthcare community as well as the tech community. Healthcare disparities still kind of sits in a little bit of a silo. I was talking with Robert and Chandra earlier that the American Medical Association, which is the largest physician membership association in the US, I think they're the largest, they had an equity roundtable, and they just ended it for want of funding, but they only needed about $150,000, which in the world that they're in is very, very small. It's like pocket change, basically. So there's still this idea that equity and healthcare disparity sort of sits on the outside, that it's seen as something you can get to later. And so there's a lot of education around just showing just how pervasive these are and how important it is, and really getting people to flip that frame of being less risk averse, because there's this idea of, oh, we can't try new things because like that presents a terrible risk and we can't risk our patients' lives. But there's the very real reality that what's being done right now is not sustainable, and what's being done right now is actually not effective. We're causing a lot of harm now from our lack of proper like innovation. And so how can we think about, kind of both de-risking innovation as well as thinking about where are ways that we can intervene. Then we're also trying to identify those same things, identifying opportunities and providing those frameworks in that direction so that we can drive innovation for vulnerable populations. And then lastly, this idea that the scaling piece, this runway, like how can we as P2 Health like really start building a fund basically to be able to invest in some of these interventions so they're not falling into this chasm of once the pilot is done, that everything is done. Because really I think that that's going to be the only way, is like getting both the financial incentives as well as the financing so that people can find the right business model and that it become more sustainable so that these things can scale to the point there. And so really trying to answer these questions like if these interventions are effective in improving healthcare outcomes, is it based on sound evidence? If it's effective, does it offer good value per dollar spent? And then also this idea too of questioning innovation, making sure you're not doing it for innovation's sake. Are there other options that achieve better results or the same results at a lower cost and like yields a net savings? So really trying to be a lot more purposeful and intentional about how money is spent and how it's linked to outcomes.